Thank you once again to ISOT for allowing us to speak on this topic and have a nice discussion. So, coming to the portal vein, again, the anastomosis is very, very critical. You need to maintain an adequate portal inflow. That is very important for graft regeneration and obviously for patient survival as well. Portal vein supplies a significant amount of blood to the liver as compared to the artery, and any technical errors you have, or if you have a size mismatch or you have a pre-existing portal vein thrombosis, then it can actually compromise your portal vein anastomosis and obviously the subsequent outcome. Now, there are various factors which are going to affect. One is the recipient factor, that is the portal vein thrombosis. The stage of thrombosis, there are various grades 1, 2, 3 and 4. It's a topic in itself separate, so I'm not going to go into the discussion for portal vein thrombosis. Cavernous malformations, prior shunts, presence of a tips, all these things can also affect the portal anastomosis. Recipient obesity, presence of diabetes or NASH or MASH, now what we call it, or MASLD, can also have a significant effect on your outcomes. And in the donor, we are looking at the portal vein length. Sometimes you may get 2 portal veins depending on the anatomy and the anomalies which we have, and the orientation as well. So you need to prepare for the variant anatomy and have backup options in your mind as a surgeon. And that is why it was the surgeon's guide. So the physician will be there. Sometimes I call up the physician on the phone and ask him, I'm now stuck. What do you want me to do? So you need to prepare. Most of the times you do prepare beforehand. So this is the portal vein anomalies. So as surgeons, we all know these are various A, B, C, D and E type anomalies. And A, B and C, maybe up to D we still accept. Beyond that, we do not accept them as for donor hepatectomy. So what are the principles of portal vein anastomosis? It has to be a tension-free anastomosis, should avoid rotation or kinking, should ensure size match. You can bevel or funnel the smaller end. You can either do it in a continuous fashion or an interrupted suture depending on an institutional protocol. You need to calibrate the lumen, and when you finally tie the knot, you avoid a purse string, so you leave a good amount of growth factor. You need to flush it. You allow some bit of back bleed, de-air both the limbs before you actually finally do the knotting, and the clamps are removed. So when you remove the clamp, again the clamps removed are in the reverse fashion, and you need to be sure that when you've done the anastomosis, the clamps were applied in a proper fashion beforehand, so that once you release these clamps, there is no twist or the orientation is not twisted completely. So this is just a schematic which showing the portal vein anastomosis, a standard portal vein anastomosis where you have a single portal vein on the this is again a deceased donor graft. So in living donor you will get a single right portal vein, and you can anastomose it to either the right portal vein of the recipient or the main portal vein of the recipient. So there are various portal vein anomalies. So the initial type A type portal vein, where you have a single, you can perform a single anastomosis, and that is what we would all prefer. But many a times you can get 2 branches. So what you can do here is bring them together, do a direct venoplasty, and then take a call whether you have got a sufficient length. You can either extend the length or you can directly anastomosis that. If there is type C or D portal vein anomaly, where you will get definitely 2 different or separate right anterior and right posterior. I'm talking about living donor liver transplantation again. So you will get right anterior and right posterior separate portal vein openings, and there you might need to do a Y graft. So here this is an intraoperative picture of a donor where you have, as you can see, there are 2 portal veins on the right hand side, right posterior, right anterior. Both these veins you will get separate openings when the graft is removed. Now here you need to decide whether you want to do a venoplasty or you want to separately join it. So when there is a size mismatch, again you can either, as we said, bevel the recipient portal vein or the graft portal vein to achieve a proper conical match. You can also do a wedge patch venoplasty, which I'll show you in a schematic diagram. I haven't done it. You can do funneling, and you don't need this mismatch to be too huge between the recipient and the donor. Otherwise there will be constant blood coming out, and you will have trouble once you open the clamps. So how they do a tapered anastomosis, this I have shown is a bevel, where you take sort of a mattress suture, and that is how you will attain a beveled anastomosis. commonly used in some centers for minor mismatches. I do not prefer doing that, and once the presentation is over, I would like my other surgical colleagues to comment upon it. But this is the graph from pictures from the Korean paper, where they tried to do a portal vein venoplasty, extended the graft portal vein where there was a large patch, cut the vein on one side, and then attach to extend the size and the lumen of the portal vein, which is to be anastomosed to the recipient side. So we don't do it. I don't do it in our center over the last almost 2 decades. So how will you manage if there are multiple portal vein orifices? As we said, you can do a direct venoplasty, or you can suture these two portal veins together and then anastomose, or you can put an autologous Y graft as a Y interposition, or as an extension graft, which I'll be showing you in the next few slides. So here, as you see, there are two veins which are very close by. This is sometimes type B anomaly, or you have trifurcation. There you'll get these two, right anterior and posterior, very close by. You can just do a direct venoplasty and then directly join it to the recipient MHV, or you can extend it. So in this case, what we did is we have done a direct venoplasty, right anterior and posterior, but we felt that this length is not enough, and that is why we decided to use an autologous portal vein graft to extend the portal vein after the direct venoplasty has been done. Now in this type C or type D, if you get, definitely they are far apart, anterior and posterior portal veins. So here it will be difficult to actually do a venoplasty, because it may lead to angulations and thereby can hamper your portal flow in each segment. So either you can directly anastomose right anterior and posterior, both you can do it to the right and the left portal vein of the recipient, or you use a Y jump graft on the bench and then make it into a single opening and then join it as the to the main recipient main portal vein. So what normally we prefer doing it is an extension Y graft, because joining two separately becomes very, very difficult in the recipient. So these are the two openings. As you can see, we tried to see if you do a plasty, but that leads to a good amount of angulation, and we are not too happy doing only a venoplasty. So we decided that we'll now do an extension Y graft. Now again, here in extension Y graft, it is important that you need to put the graft and look at the lie and then trim the autologous venous graft, because sometimes there is length discrepancy, and when you are anastomosing two separate portal veins, one you may require one limb, you may require a longer length, in the other limb you may require a shorter length. So all those need to be decided once you have actually placed the stay sutures. So place stay sutures on both the sides, typically at the corner, and then started the anastomosis, confirming the lie, and then we end up doing the anastomosis. So this is the completed picture, where, as you can see, these are the two anterior and posterior portal veins with an extension. There's an anastomotic line here seen, another line, and this is the anastomosis between the main portal vein and the autologous extended graft. So this was again, some people can do a dual anastomosis, as we were speaking, but I find it very difficult to do a dual anastomosis separately. The right anterior, because of the short length, and you may not be able to pull it or stretch it and allow it to reach. So doing and extending it on the bench is comparatively much more simpler than anastomosing these two separately. Now the question somebody had asked, if there is a short portal vein, so what do? You try to mobilize, get good enough length, but sometimes you find that the portal vein is not still usable. You try to push it to the posterior attachments, anterior attachments, there are multiple nodes around. Then the options you are left with is an interposition conduit. So what are the interposition conduit you can use? Is usually the most preferred one is the internal jugular vein, because that would be a decent size match. You can use iliac, specifically if you have a cryopreserved or cadaver iliac veins, or the portal vein, again autologous portal vein you can use if it is from the previously cryopreserved. Again, but there's a time duration and living donor program. Unfortunately, we do not have access to iliac or cryopreserved portal veins. So the idea is that if you get stuck, you will have to use interposition graft. So as we discussed, this has already been spoken about. So interposition graft, as we discussed, you can try and use the internal jugular vein, and this is one of the from one of the papers which has been taken, where the anastomosis was done as with the use of autologous interjugular vein conduit. Synthetic grafts, again, rarely, very rarely used in portal vein, but we would like to present a case where, again, in last 18 odd years, this is the first time we ever had to use synthetic graft, because we had a case of CLD with Budd-Chiari syndrome, short statured. We required a good length of the portal vein. Unfortunately, the portal vein was not suitable to be used. We tried looking for a great saphenous vein, too smaller in caliber. The internal jugular vein, again, we did not want to take it from the donor, and in the recipient, because of the short stature, we found that the length of the internal jugular vein was significantly less, and that is the time we decided to use the portal vein PTFE graft as a synthetic graft, as a portal vein conduit. So this is the pre-op CT of the recipient, which is showing a large liver with hepatic venous outflow tract obstruction, multiple regenerating nodules, lot of ascites, and at some point the portal vein had thrombosis as well in it. Portal vein was completely compressed. That's the left portal vein was seen, but the main portal vein wasn't too good, which will be showing an intraoperative video as well about it. So that's, keep following it down, and the length was pretty much short because the liver, due to the hepatic venous outflow tract obstruction, the liver had enlarged significantly. Thereby, the actual portal vein length was significantly smaller, and we had some bit of thrombosis there in the portal vein, and we felt that the wall of the portal vein wasn't too good to be utilized. So that was the splenic junction. Also, the splenic vein has also come into the view here. So there's a very, very short portal vein. So that's the caudate lobe of the same patient. That's a huge liver, so there's hardly any length left. Cava was good mobilized, but as you can see, the portal vein, not too good flow. Look at the portal vein, which we tried to open it again. We didn't find the intima to be utilized for anastomosis, so we went down to superior mesenteric vein SMV, used a jump graft there of PTFE, and brought that jump graft supracolic compartment, and completed the portal vein anastomosis as you would do otherwise in a regular fashion. The rest of the things were done as you would do for the standard anastomosis, and this is the post-transplant CT showing a patent PTFE graft. Let's make a second there. That's the portal vein coming up. Yeah. Going down and joining to the SMV. Portal vein thrombosis, again, it's a topic in itself, and I really don't think, because that's a completely separate. But if you do have, you can actually do a thrombectomy. There are various ways of doing a thrombectomy. There's an eversion thrombectomy. You can remove the thrombus under direct vision. You can do a venotomy. You can go for a SMV jump graft or renoportal anastomosis. So just for the sake of completion, I added this here. If the renoportal, if you have to use the renoportal, if even the SMV you're not able to get the inflow, then you end up doing a renoportal anastomosis, which is technically a non-physiological reconstruction. But if you don't have any other option, then that's the fallback option. We have in fact done a hemi-caoportal transposition as well. So that is another thing which can be done. Portal inflow modulation, there is the next talk on small for size, so I'll skip that. And to conclude, that portal vein reconstruction is very much essential for successful liver transplantation, influences the graft and patient survival both. Understanding a normal portal hemodynamics and anatomic variations, and portal vein thrombosis with the grading you can allow you to plan pre-operatively. But if you do end up in situations where operatively you may find it completely different, then you need to have backup plans ready, where you can use either an autologous or a synthetic extension conduit graft. So thank you very much for your attention.